All right, so this is a broad overview of the many different options that we have to treat perimenopause and menopause symptoms. We generally separate it into two categories: the hormone medications, which is what a lot of people are most familiar with, and then the non-hormonal options as well. So the non-hormonal options we'll also talk about a little bit towards the end, but importantly, there's medications, there's supplements, there's lifestyle changes, and then for hormonal, we're going to get into talking about estrogen and progesterone and the risks and benefits of each of those things. Right. And then one more thing about this, so when talking about the methods of each, we're going to talk about how there's not a one-size-fits-all for hormone therapy. There are so many different routes of the medication. We have patches, pills, rings, sprays, injections, creams, lots of different options. All right, so one of our favorite things to do in clinic is, and you get hormones, right? Okay, so importantly, just kind of the statement for hormone therapy. Hormone therapy is the most effective treatment for vasomotor symptoms, so that's the hot flashes, and genitourinary symptoms of menopause, which is like that vaginal dryness, and has been shown to prevent bone loss and bone fractures. So we talked about the many options that there are, and it's not a one-size-fits-all. There are two hormones we like to prescribe the most, which are estrogen and progesterone, and depending on your symptoms, your medical history, your surgical history, one or both of those will be the right choice for you. And our goal overall is that we want you to be on hormones at the lowest dose to minimize risk for the shortest amount of time possible to still make an improvement in your life. And when we decide later on when to discontinue that is a very individual discussion and something that you have with your provider. All right, so the risks of estrogen and progesterone and hormone replacement therapy in general are really important to talk about because they haven't been the most well understood until more recently. One thing that's really common to hear about are breast cancer and blood clots and stroke. The best thing about hormone replacement therapy is that for people who are under the age of 60 and within 10 years of their last period, the risks of hormone replacement therapy are overall very low and the benefits far outweigh the risks, and it is generally very safe. So one of the things, like I mentioned, so breast cancer. I think a lot of people have probably heard that hormone therapy will give you breast cancer. So that used to be thought to be true 100%. However, especially recently, we know that very specific kinds of hormone therapy started at a specific time can actually decrease your risk of breast cancer and stroke. However, there are combinations that do exist that can increase your risk of breast cancer. So it's important to know that you can't cover all of these, all hormones into one basket. They are very different and each have different risks and different ways that you can and shouldn't be a candidate for them. All right, so who is a candidate for them? So the biggest contraindications or reasons that we could not give you hormone therapy, so that is a history of breast cancer, active or recent stroke or heart attack, or blood clots in your legs or your lungs, active liver disease, or known or suspected cancer that's sensitive to estrogen. So that's usually like a uterine cancer. And then one common question we get a lot is having a uterus, does that mean I can't have hormone replacement therapy? No. That means that you need actually a specific kind of hormone replacement therapy. But having a uterus does not by itself mean that you cannot get hormones. All right, and one medication, so there's a lot that we talked about. One that I think deserves special mention is vaginal estrogen. It is a wonderful medication. It is highly effective at treating the genitourinary symptoms of menopause, so that vaginal dryness, discomfort that we talked about. And unlike the other methods that the hormone replacement, this is not so much hormone replacement in the traditional sense. It's a very localized way to deliver hormone that will really help with the vaginal discomfort, and it has not been shown to increase your risk for anything significant like breast cancer, heart disease, stroke, or blood clots. So it is very safe, and almost everyone is a candidate for it. And one wonderful thing about it is not only does it help decrease pain, improve lubrication, it also will decrease your risk of getting urinary tract infections at that point in life.
So what about testosterone, you may be asking? This is endorsed by some societies for treatment of low libido or low sex drive, specifically in women who have already gone through menopause. When we do talk to you and prescribe testosterone, the dose we're going to recommend is going to be a very low dose. Women in general need about 1/10 of the dose of guys. The goal is to keep that testosterone in the premenopausal range. So this is a hormone we would test you for after putting you on testosterone every 3 to 6 months until our levels are stable to make sure that those levels are not getting above a normal female range. This is not approved prior to menopause, but could be considered for shared decision-making for someone with low libido. Of note, there are other treatments for low libido, which we can talk about in the office, such as talking to a sex therapist, and some medications like flibanserin, remilonidine, and antidepressants. But again, that's a specific conversation and would be specific to your needs. Why we don't recommend testosterone pellets. You may have heard of testosterone pellets. Some of you may even have pellets. Looking at what the data says, there really isn't any FDA-approved testosterone formulation. The concern with pellets in particular is there isn't good safety data on them. They can be difficult to remove. Once they're in, they have to dissolve, and they dissolve over a long period of time. There's also no way to know exactly how much is going to be released and how your body's going to react to the amount that's released when it is dissolving. So you can have side effects if the testosterone released and absorbed in your body is too high and higher than a normal premenopausal female range. This can put you into male level ranges of testosterone, which can cause abnormal hair growth, acne, virilization, where your body starts to change and become more masculine, your voice can drop, and you can have abnormal bleeding. Some of these symptoms are not reversible, and the effects of long-term use of testosterone, especially higher doses of testosterone on cardiovascular disease and breast cancer risks, are unknown. So we would strongly caution against using testosterone pellets because we know that the creams are safer and it's easier to get you titrated to the right levels. What are some non-hormonal options that we could consider? Let's say that one of those contraindications applies to you, or you are hesitant to try hormonal treatment for your menopause symptoms. There are other options out there. We may talk about antidepressants, so SSRI or SNRI, that's things like Lexapro, Paxil, Paroxetine. Those medications we don't just use for mood symptoms. They can also help with hot flashes and with sleep. Things like gabapentin can help with hot flashes and sleep as well as pain. Then there's clonidine, which is traditionally a blood pressure medicine. We don't use it as often, but it can still be considered. And then there's some other newer options like selective estrogen receptor modifiers that, as the name suggests, they modify the amount of estrogen in your body. And Veoza, which is a neurokinin receptor antagonist. That's fancy words to say that Veoza works directly in the brain where that thermoregulation happens to decrease hot flashes. We can also add on a vaginal moisturizer, a lubricant, plus vaginal estrogen or not. And then there's lifestyle changes. So briefly to talk about lifestyle changes here, we'll talk about them more later. But in general, women who are perimenopausal and menopausal need more protein because your body is changing. It's wanting to store that visceral fat. The way to combat that is to keep up our muscles. The way we do this is by doing exercise with some strength training a couple times weekly and adding in some protein to help build those muscles. That's 1 to 1.2 grams per kilogram daily. That is largely through food intake. So we want to add in some lean protein options. In addition, we want fiber, so 25 grams a day, that'll be fruits and vegetables. And we want to decrease our added sugars, so decrease things like soft drinks and sugary coffees and desserts. Keep it less than 25 grams per day. That doesn't mean you have to stop having dessert altogether. It just means we have to watch and limit that amount. We also want to be looking at whole grains. So instead of white bread, adding some wheat bread or some quinoa and other good grains that your body will take longer to digest. We'll talk about calcium and vitamin D and how much of that you should be getting in the diet. And a good diet to look into if you're wondering, well, gosh, how do I make all these changes? It seems like a lot to keep up with. The Mediterranean diet meets a lot of these criteria just on its own. So if you follow a Mediterranean diet, then you'll have some good suggestions for how to incorporate these changes while still eating good, tasty foods. Exercise, in addition to strength training, we want to be doing some moderate aerobic activities. This is brisk walking, running, Pilates, 150 minutes a week. And then we want to try and sleep. It's harder to sleep when we're in menopause, which if you're having insomnia, come talk to us. But we want to try and get 8 hours a night, and this means limiting our alcohol intake before bed and limiting our screen time before bed.